Greetings, fellow scholars and Dr. Buckles. I am Rachel Booth, and I'll be presenting tonight Integrated Trauma Treatment, the empirically supported treatments for trauma, and a Christian worldview analysis. So the overview of the presentation includes Introduction to Empirical Treatments and PTSD, Cognitive Processing Therapy, Personal Counseling Theoretical Orientation, Internal Family Systems, and Art Therapy. So PTSD, post-traumatic stress disorder, can develop after experiencing or witnessing a traumatic event such as rape, assault, combat, natural disasters, car accidents, airplane crashes, terror attacks, bombing, torture, serious bodily injury, etc. PTSD is characterized for diagnostic purposes by the cluster of symptoms that meet criterion A through H from the DSM-5 classification for PTSD. PTSD diagnosis includes trauma exposure and experiencing symptoms persisting for at least 1 month after exposure. Individual responses to traumatic events necessitate a variety of treatment options. Symptom severity, previous traumatic experience, previous mental health issues, cognitive level of functioning, moral, religious beliefs can all inform treatment. Due to the complexities of trauma, treatment options vary, and we've learned so many in this class, or relearned, or however that looks for each of you. Tending to all parts of the client, though, will require an eclectic approach to therapy, which I like to think of as a holistic view. Clients with PTSD oftentimes present with comorbid diagnosis, which requires clinical insight for proper treatment. The comorbid diagnoses could be substance use disorder, anxiety, depression, dissociation, bipolar, to name a few. So let's jump into CPT now that we've identified PTSD, that is our clientele, and so treatment options for PTSD. CPT is considered one of the gold standard treatment options for PTSD. This evidence-based treatment is endorsed by the U.S. Department of VA, Veteran Affairs, and the Department of Defense due to the higher prevalence of traumatic exposure that the military combat veterans are dealing with. So CBT is a cognitive behavioral treatment. I'm a CBT counselor, so this one is very much appealing to how my brain and how I operate on the daily. In CPT, clients will learn how to reconceptualize the trauma by challenging inaccurate beliefs and differentiating the maladaptive thoughts and feelings they're having. This is an active participation for clients in and out of session. They have weekly homework activities. And if you're meeting bi-weekly twice a week as the treatment is the recommendation, then they will definitely be doing homework. So letting them know in advance that there is going to be outside activities to do is very important. Explaining the model to the client, which is in the first session. So CPT can be implemented in a variety of clinical settings and can be delivered individually or in group therapy. This is a very structured model, and it is effective with civilian and military populations. We mentioned the military, but it's also effective with civilian populations. It's multiculturally appropriate, can be adjusted for language variances. It's utilized all around the globe, different translations, cultural adaptations, and cognitive ability. So if you have a client who is maybe lower functioning, and it's noted or evident, or younger, there is a modified version with the CPT that I learned about in the training that you have access to if you have all the material. So that's great. This CPT can also be utilized with adults, adolescents, and LGBTQIA population. So it's very covers pretty much everybody. CPT treatment includes pre-treatment evaluations. So the PTSD checklist, the PCL5, you actually will administer it all throughout the 12 sessions, definitely beginning, mid, and end, but multiple times if needed, just to kind of gauge your client's progress. The patient health questionnaire, the PHQ-9, is administered in the beginning of treatment. Clients will receive a manual, and it's going to have all kinds of handouts. So these worksheets are going to be completed out of session, in session, and reviewed. They're weekly homework assignments, which are empowering the client to integrate the tools they're learning in therapy. So as a former teacher, and some of you are already professors or teaching, I feel like this model would appeal to that side of your instructional mind, because it definitely is, you're explaining, you're working through, you're asking good questions, and you have worksheets in a notebook. So it's like school. But the client needs to know that. So CPT does consist of 12 one-hour sessions twice per week. It can be terminated early if need or go longer. It depends on the client. The recommendation is 12. So the between session assignments are foundational to effective therapy. Patients will learn to recognize and challenge dysfunctional cognitions related to the traumatic event. So the counselor, I think the biggest adjustment for the counselor is using Socratic questioning. So the counselor is going to help the client examine the facts and content surrounding the traumatic event, not just asking questions and letting them answer, or helping them understand, but it's a different line of questioning, which I think, based on what I've learned and from the training, that might be a little bit, that's the hardest part for the counselor. So Socratic questioning, what do you mean by? Could you elaborate? Could you give an example? If that were true, what else would be true? So some of this language is familiar to counselors, but it's just this whole line of questioning that is the primary way that you help the client dig into these stuck points that they have with the trauma. So once the clients are able to label the events, thoughts, and emotions, and you help them understand the difference between feelings and facts, right? How they feel in their heart and facts in their brain, the cognitions, or just information, right? So it helps them recalibrate the unbalanced thinking regarding the event. So there's so many handouts, and you do need to go in order when these, like TFCBT, which is one of my favorites. The structure is intentional. That has to do with the success of these models. So with the handouts, again, you don't just pick one that you like and use it every time. You do them in order. So here's the list. The impact statement is where you begin. The stuck point log, that's an ongoing document. The ABC worksheets can be added throughout. Levels of responsibility, exploring questions, these are all worksheets. Thinking patterns, alternate thoughts, safety issues, the trust star, that was a fun activity that you can do in a session. Power control, and then the power control alternate thoughts. So these handouts do guide the 12 sessions and provide the client with the personalized data for progress monitoring. So you literally have the empirical evidence. You see it, they see it for this model, and that's very powerful. I did the CPT training for our continuing ed credits. I know some of you did as well, and I really do feel like I want to get certified in this because it's brilliant. It feels time consuming and rigid, but if it works, it works. And the data doesn't lie, at least what I found. So the index trauma is the primary focus of therapy. So where we start, we all know this in therapy, we can end up many places, but the index trauma, for example, the rape or the car accident, whatever it is, that's the main trauma that we start with as the counselor with the client. But as sessions progress, stuck points are discussed, alternate traumatic experiences can arise, and this is when you circle back to the worksheets and you use the ABC worksheets and stuck point log. So at the onset of therapy, the client is creating an impact statement. Now, this is their retelling of the trauma. They read it aloud to the counselor to be discussed at length. So the client will create an updated impact statement at the closure of therapy, and this is another measurement of progress and just validation of the experience of CPT, because the client literally sees their own writing, and it's a compare contrast tool. And even the vocabulary and their adjectives, how their whole point of view has changed. So it's a very effective tool for the counselor, for the client. So yeah. So the impact statement is their version, their summary of the traumatic event. And reading it aloud, of course, is also just a powerful experience. So in that impact statement, what was the cause of the event? What effect has it had on their life? How has it affected the following areas? So in addressing safety, trust, power control, esteem, and intimacy, client might not write all of those things, but it's kind of foreshadowing of what the tools are going to learn about cognitions and at the end of the sessions. So addressing safety, trust, power control, esteem, intimacy. So oftentimes trauma memories can become fragmented. So writing the trauma narrative can actually reconstruct the event. If the client has never put it on paper, then that might help put pieces back together. Just brilliant each step, right? So case conceptualization skills for the counselor include, so as a counselor, this is the vocabulary, this is the language. We're not like saying, oh, that's assimilation, oh, you're over accommodating client, but this is the language that we're listening for, what the client is describing. So assimilation is this new information when they're bringing in existing belief structures without modifying the structure. Accommodation is modifying the beliefs to incorporate new information about the trauma without overgeneralizing. And then over accommodation is when people are radically adjusting their beliefs as a result of the new information or the trauma. So you always hear the over accommodation. Assimilations can be subtle, but the accommodation is the goal of the end goal, if you will. So an example of assimilation is the trauma happened because I did something bad. Like, they've assimilated the event and they are at fault. The accommodation is I know that bad things can happen to me, but I'm still able to feel safe. So in my mind's eye, as I was writing this, I was thinking of rape, of the case study, because that's kind of language. It could be applied to anything, but if you just want to put that in the back of your mind as you are looking at this. And then over accommodation is everyone is out to get me, or because I was drunk, I got raped, or, whatever it may be. But again, like I said, the end goal for CPT is that clients have accommodated beliefs about the traumatic event. The self-blame, the guilt, the shame, all of that language is no longer part of how they're describing what occurred. So clients will learn to explore their personal cognitive bias, overestimations of safety in dangerous situations, and honestly assess their level of responsibility and blame in the trauma. Clients with PTSD often do have a strong need to understand the cause-effect association of events, and their just world belief poses that good things happen to good people and bad things happen to bad people. So there are terms in CPT that are specific, like the just world belief, the over accommodations, that you as the counselor will become. If you did this all the time, you'd be very comfortable and knowledgeable in hearing those expressions from your clients, or those thoughts rather. So this belief system can create many stuck points for a client that will be addressed in session. So the CPT plus A was the original form of CPT, which included 2 written accounts of the indexed traumatic event, but the written account can be omitted in CPT. So there's data and research of the effectiveness with or without it. And some of the information that I was looking at did indicate that without the written account, it's equally effective. But I feel like that is the most powerful tool. So unless the client is completely resistant to it and you obviously don't want to force them, I would highly recommend doing it. So both CPT and CPT plus A have yielded positive outcomes for the treatment of PTSD. But again, depending on the client levels of dissociation or other comorbid diagnoses, you just have to be mindful of that. So CPT sessions should be implemented in order and with fidelity. I said that earlier. The out-of-session homework worksheets, addressing additional stuck points, and staying on track with sessions all contribute to the efficacy of this model. The final sessions do provide an overview of themes that affect the core beliefs once they learn all this language, such as safety, trust, power control, esteem, and intimacy. So by addressing that in the front end, then you wrap up the whole sessions with these themes. And then a session will be allocated to address each of these core beliefs with related activities. So this is towards the end of the sessions. So as the client does develop the skill set to distinguish between thoughts and feelings, identifying maladaptive cognitions, and questioning their own thoughts, they are in essence becoming their own counselor. That might feel intimidating to some counselors, especially the seasoned ones. But again, it's just creating the autonomy for the client to leave and maybe just only come back for a check-in, not to be with you forever, because they are now empowered and have the tools truly to move forward, because more crises will come. Early termination can occur if the patient progresses and the PCL5 results indicate minimal or no evidence of PTSD symptomatology. One of the cases that was in that training, the client's PCL5 at the midway, third wave through, indicated no evidence of PTSD. So they did terminate early. So that was great because the client had done the work and it was pretty astounding. And I don't know, I think they were acting, but it was helpful, encouraging to see that it can be done in less than the 12 sessions. So CPT does yield long-term results once the client embraces cognitive change, resulting in symptomatic improvement once they recognize their personal power to change the maladaptive cognitions. The most powerful tool in CPT is the final impact statement. The measure of progress is exemplified in the client's beliefs about the event. The traumatic event didn't change, but their views and feelings toward the event are evident as they are read aloud and can experience a cathartic moment, realizing the very much personal growth that they have achieved. So here's just a visual of just how that looks like, learning what it is. So there is a psychoeducational component in the front end, which I didn't really mention, but the whole thing feels psychoeducational in a way. So once they learn these skills and challenging their thoughts, they can learn how to cope. So CPT, I believe, integrates well with a Christian worldview in a practical manner. Honesty, it does require discipline and fidelity are core facets to this technique. Therapeutic relationship is foundational CPT. So we're looking, obviously, that's trust, transparency, mutual respect, safety, and unconditional positive regard are all facets of the total acceptance of God's love. Clients with PTSD often experience high levels of guilt and shame, and the Christian counselor can work with the client for these specific things, identifying pseudo-guilt and self-imposed shame. So religious beliefs hold expectations such as God owes me. Sometimes people think that, or if God's real, why didn't he intervene and allow this to happen? Those are good questions or statements. And these religious dysfunctions, as we're going to call stuck points for CPT, are an opportunity for the counselor to discuss religious motivations, acceptance, grace, and forgiveness for themselves, self-forgiveness. So religious dysfunctions can result from traumatic experiences that clients have survived, faulty beliefs regarding suffering, and religious motivations. So that's something else to address because suffering is unavoidable on this side of eternity, regardless of religious beliefs. However, once the client learns how to challenge the faulty beliefs, they can discover ways to make meaning out of the experience with an eternal perspective. And that might not ever happen in your office, but you plant that seed and hope that eventually they will see that God had his hand on it and he can make a message out of the biggest mess that we encounter in our lives. So once the skill is developed, it can serve the client if and when they'll be triggered or when another traumatic event occurs. So my personal counseling orientation, we're just going to kind of pivot there so that way you can frame out the rest of what I'm talking about. So CPT was appealing to me because CBT is my primary technique. But for a trauma-informed approach for my personal counseling orientation is the very basic what the trauma-informed counselor should have, right? Safety, trustworthiness, transparency, collaboration, mutuality, empowerment, voice and choice, and multicultural awareness. So theoretically, I'm a CBT counselor, and I am a big fan of Gestalt and experiential therapy. Practicing, I guess I should say. Positive psychology, though, has been something that I've been recently adapting in addition to solution-focused brief therapy just because of the setting where I work and the limited time that I have. So these treatment options for my personal counseling orientation do pair well with CPTs simply because of the cognitive-based therapy. It's founded upon that CPT. Internal family systems, as we see in art therapy for PTSD, kind of are additional ways that I can work with clients, and especially art going on a creative side. Maybe the talking isn't working. IFS is just really unique. I feel like for our, I had really, I haven't utilized it really after this course though. I might perhaps, because I like how it can really be tied in with like your if you are a Christian and treating a Christian, just how the man consists of mind, body, soul, and spirit. So we'll get to that in a moment. Psychotherapeutic efficacy of PTSD treatments is dependent upon a variety of factors. So severity of treatment, exposure frequency, length of time since the event, previous trauma history. So because that is true, I do believe that we have to be equipped to help clients with PTSD. Multiple psychotherapies are available for PTSD. The first line of treatment includes some form of CBT. Of course, we know EMDR and then prolonged exposure are also very much the most effective treatment options. So pre-exposure to treatment could include psychoeducation, emotional regulation, and dissociation management. So the primary focus though for the client, whatever I'm using, is always the cognitive work. That's where I start, identifying, challenging, and changing maladaptive cognitions, and how that looks and what other techniques I utilize. That's where I begin. So Christian worldview, that one always is interesting because if it's innate, it's who I am, it's what I believe, it shapes my faith, shapes everything. So for me, it comes out, it's within me, but it does integrate for purposes of the course with my personal theory of counseling in this way: unconditional positive regard for every client, maintaining a non-judgmental attitude despite religious differences or any differences, accepting, encouraging, and equipping clients to overcome life's challenges, drawing upon eternal perspective by learning how to hold the tension between what we believe and what we experience. That one's real hard because if God's a good God, then why are all these horrible things happening? So it is that tension of what we know and what's happening, what we believe and what we're experiencing. And then accepting that God's will is beyond our control. So it's not God's will that you are raped and that you experience horrific events. We live in a fallen, sinful world. And the book of Ecclesiastes is one for pondering because, good guys get the bad deal and the bad guys get the good deal. So, it's just part of faith requires action. And so as a believer, we get to put this into practice in more ways than we probably even realize. So, okay, so that's me, that's CPT. Now let's pivot and look at IFS. So internal family systems. So this one was fairly new to me. I'm not, full disclosure, but I do believe that if you get a handle on it, it could be very, very useful. And again, I don't work with families, I work with adolescents and young adults, but I do feel like this is, a great option when working with clients with PTSD. So internal family systems is a versatile approach to psychotherapy, and it's theorizing that the mind is a plural entity with numerous subpersonalities. So this is when, if you're like spiritual, this can get really, you can kind of geek out on this. At least I feel like I did. So these subpersonalities consist of wounded parts and are often in conflict with one's core self. So the different parts of the self are the vulnerable parts and the protective parts. And the parts represent the memories and emotions that are associated with the trauma. So symptoms of PTSD, the avoidance, hyperarousal, numbing, shame, guilt, along with depression, anxiety, or dissociation are conceptualized as the internal system's best attempt to survive and cope. So IFS does use mindfulness, self-compassion, and self-acceptance to work through the parts of the self that are holding on to pain. So you have to, if you're not really into mindfulness, I don't think this is one you should pick up, or maybe it is exactly what you need to pick up because you need to open your mind and become more mindful. How about that? It's not that's not very doctorate level language, but maybe somebody got amused. Okay. So why self-compassion? with self-compassion, the client can process the traumatic event in a safe internal environment. Self-compassion becomes the change agent to process the guilt, shame, and self-blame associated with the trauma. Mindful observation of the somatic effects in the body increase the client's awareness to tolerate the difficult memories. So as this is happening, their confidence in their own ability to work through discomforting thoughts and memories. So really just getting in tune with what the client's experiencing in their body and where and how they're holding it. And so it's definitely giving you some creative outlets in that way. So by releasing the suppressed emotions, the conflict between the parts of self are muted or they cease completely, and that internal tension is reduced, and that's when maladaptive cognitions can be restructured. So safety and connection are key to being reestablished within oneself, and then balance and harmony are restored within the internal family. So the internal family is who we are on the inside. So with IFS, the client transitions from a place of hurt and protection to connection and authenticity. And IFS does have that spiritual component, drawing upon concepts of chi, Buddha, prana, soul, spirit, Christianity, inner healing, and universal life force. So for this reason, it does integrate well with the Christian worldview. And then Christianity, now we'll wrap that in. So Christianity posits that man consists of body, soul, and spirit, similar to how IFS draws upon connecting to one's internal psycho-spiritual world. So the battlefield of the mind is where truth and lies are warring against each other. And this tension that exists for believers is what is seen versus what one believes, as I already mentioned. And we live by faith and not by sight. And, faith is a verb. It's a noun. And it's an adjective. So it's one of those things. It's tension, and it does pair well with the Christian worldview, but you would have to be very much open to what other people's views on spirituality are, and to not offend, because offense just breeds division, and that's the last thing you want to happen when you're in a room with your client and somebody gets offended, and now your therapeutic alliance is severed. So just being mindful of things like that. Clients with PTSD oftentimes struggle with moral injury. Clients who already have a religious moral framework are not always exempt from a moral crisis, which we know, but it's good to mention again. And these competing and incompatible beliefs can be addressed with the counselor in a reflective capacity, with grace, mercy, and non-judgment. So unburdening is a facet of IFS, which is similar to surrendering all fear, anxiety, and worry to God. The word speaks so much of that. 1 Peter 5:7, cast all your anxiety on him because he cares for you. Romans 8:6, the mind governed by the flesh is death, but the mind governed by the spirit is life and peace. And once we surrender our will and our human frailty, only he can give us the peace that passes understanding, the shalom. So 1 Thessalonians 5:23 and 24, I feel, is a leading scripture for IFS from, and I think one of the videos in the course posted, the therapist referenced this, but absolutely. So may God himself, the God of peace, sanctify you through and through, and may your whole body, spirit, soul, and body be kept completely blameless at the coming of our Lord Jesus Christ. The one who called you is faithful, and he will do it. Well, he's going to do it. We're just the vehicle to help get you there. So yeah, I think IFS can really be integrated so well with a Christian worldview, because it does address self-blame, guilt, and shame to restore harmony up amongst the parts of the self. And when a client adopts new beliefs about their worth, hope and faith can be redeemed, restored, and strengthened. So truly, the promise of restoration is for all humanity. And IFS, I think, really draws on that. So last one is art therapy. Now this one, I feel like many counselors, therapists can use art therapy for many things. Just attuning to the creative process. Art making and applied psychological theory to address, this is what art therapy does, the emotional and mental issues the client is struggling with. So this is a multisensory approach. It does include kinesthetic, sensory, perceptual, and symbolic methods for communicating. And this is great if talk therapy hasn't worked, or perhaps the client just doesn't want to talk, or they're young, or they're elderly, or or the trauma was too intense. So by processing thoughts and emotions through imagery, the client has a freedom to express themselves in a non-traditional and creative way. Art therapy includes creative self-expression while integrating nonverbal communication through visual narrative. Masks are a part of, what the core of art therapy was done with the military population. And it was so interesting to see how much breakthrough they had because they couldn't talk about it, but they could paint it, they could create. So trauma can be encoded through visual images. So because through our eyes we see, art therapy is consistent with that sensory encoding component in our minds and our brains and our bodies. So service to military populations is at the core of art therapy, which was developed from treatments of battle fatigue, actually. Artistic expression through the use of drawing, painting, or sculpting can assist the client to process emotional, mental, and social issues. Art heals. This technique can be utilized with all ages, populations, and clients with previous mental health history. When clients find verbal expression challenging, this alternate approach can prove to be highly advantageous. And studies indicate that art therapy helps clients with gaining control over what is past and present, regaining control. So this indirect, nonverbal, experiential approach can be integrated with other forms of trauma therapy, or it can be used as a standalone. Art therapy reflects the wordless, visual, and sensory nature of traumatic memories. You don't have to be artistic to do this. You just have to pick up a paintbrush or have somebody guide you in your process, whatever the mode is. This process can be cathartic for the client while making them more receptive to other techniques. So art therapy also integrates well with the Christian worldview because I feel like expressive therapies do. Here we are again. Man consists of body, soul, and spirit, and art therapy draws upon the spiritual nature of man's creativity. We're made in the image of God. He's the creator. So our creative expression is innate, which can be further developed with art therapy. And when people say they're not creative, I say, how can you not be creative? You were made by the creator. So similar to faith, which is limitless. It's deeply meaningful. It's giving you an opportunity to express a unique expression for each person. And art therapy does give the client freedom of expression without judgment because there's no rubric, there's no criteria, there's no, this isn't perfect, this isn't graded, right? It's just what is happening in that moment. So the Bible, if we really start exploring, it's filled with music, poetry, creative expressions, and lyrics that are profoundly impactful. The Christian counselor can draw upon the creative nature of each client as we are all fearfully and wonderfully made. He's made everything beautiful in his time. I love this one. Ecclesiastes 3:11. He has set eternity in the human heart, and yet no one can fathom what God has done from beginning to end. So that to me pulls on your creative side. If eternity is set, I mean, everyone thinks of what happens after they pass, but it also is like an imagination, and that just draws on your creative expression because you imagine what life would be like. So, I mean, we truly are. God is so cool. This speaks to man's ability to create, design, and wonder, and just wonder about the beauty beyond the confines of this life. So, wrapping it up, hope you're still awake. My personal counseling theoretical orientation has evolved over years of working with trauma. CBT is my primary theory, however, integrative approach to trauma is most advantageous for the client, providing wraparound services for optimal care. Holistic approach is where I go and where I start in it. Upon further examination of CBT, not only is it empirically sound, but can yield long-lasting positive outcomes for the client. In an effort to avoid or prevent a PTSD relapse, though, clients need to be fully equipped and educated with tools to be able to continue in life, since trauma is inevitable. Treating each client with a holistic approach while tending to the cognitive, emotional, and physical effects of trauma can be accomplished using all the modalities discussed, CPT, IFS, and art therapy. CPT provides the needed structure for the client suffering from hyperarousal flashbacks and difficulty concentrating. IFS treats the different parts of the client self, and art therapy describes the trauma without using words, which is that alternate approach to healing, which provides. The trauma journey is unique for each client and their results will vary. The goal of therapy is to relieve, not intensify the trauma. So with an integrative approach, though, the trauma-informed counselor can lead the client towards healing and wellness. The helping profession is truly a calling and not for the faint of heart. It requires patience, grace, wisdom, discernment, and creativity, which we've seen in this class. And it just brings me to a promise from heaven, Luke 1:37. Not one promise of God will be empty of its power is the front end of that, for nothing is impossible with God. So I hope that this information was helpful in some way, and I'm looking forward to feedback. Those of you that actually utilize CPT, IFS, or art therapy constant or frequently, I would love to hear from you. And then anyone else, just anything at all, any feedback. This class has been so rich with information, and I feel like I have more tools, not enough time to help my clients who are suffering from trauma and PTSD. I thank you all for your attention. I know this was long, and best of luck on all of your presentations, and we're almost done. Yay! Okay, good evening. Goodbye. All done.